of what the bill does is to actually help those who are smoking to stop, in as much as it helps those who have not started not to start. We know clearly there's a lot of studies that have shown when you actually, and I've also published studies from South Africa that shown that if you reduce the appeal of the appearance, you reduce the expected sensory experience when you have that pack as a plain pack. And therefore, the smoker is less likely to be further interested. And if you get support, it would quit. So I think there's an assumption that the bill is meant just to prevent people from starting. Everything in the bill, if you have 100% smoke-free environment, once you can break your chain of nicotine for even an hour that you can't smoke in a public place, your chances of being able to stop increases. So everything in the bill is also about smokers. Comparative study, smokers, we do have that. I've not broken that down to poor areas and rich areas. I'm happy to do a secondary analysis and provide that to you. The honorable member also asked whether we've had any population study. All the studies that we've been doing are population-trained studies. And all the studies I've provided to you are population-trained studies. I've conducted clinical trials in TB clinics, the largest in South Africa and the first. And I can also provide that to you. That is for smoking cessation, just to make sure that you're convinced that my primary interest for many years, I have trained more than 1,000 people on how to give smoking cessation brief motivational interviewing. And I also serve on the smoking cessation group of the International Association of Study of Lung Cancer, So smoking cessation as a clinician has been my primary, but I realized that without understanding and getting the policy right, we would not get people to stop smoking, because once they leave your clinic, they go to the spa and they see those cues and they relapse. The e-cigarette likely to relapse, why is it different? And at the same time saying SRT was as equally effective. I think we need to get the nuances right. NRT is equally effective was the Cochrane study, looking at 6 months. The study we looked at was beyond 6 months, beyond 12 months. And that's the difference. Cochrane RCTs are usually focused on 6 months time benchmark. But if you follow them beyond 12 months, you might be able to get a better understanding of relapse. And that's just to clarify the difference in that study. Vaping increase and smoking increase, whether we consider harm reduction. Yes, indeed, you cannot have any better example for that. All the examples that have been shown from other countries are based on population trends. The time vaping goes up, e-cigarette goes down. Time snus goes up, e-cigarette. But in South Africa, despite the fact that there is illicit, the point is whether it was cheaper or not, people did not move. And that's the point about harm reduction or the switching, to be very clear. People did not switch. So the point, therefore, is the reality. I think what we call the common sense science. The reality is that people are not likely to switch in South Africa like in Sweden, except you make the tobacco control stronger. And I think that's the point we are making. We need to introduce plain park. We need to ban smoking in public places. We need to address the illicit. Montenegro had illicit at 51%. It introduced plain park. It was able to bring down the smoking rate from 40% to 25%. What we're saying is that in presence of tobacco control, if there's going to be any benefit of harm reduction, it has to come with plain pack, burning, denormalizing smoking. Because if you have people smoking vaping even in public places, you make it difficult to explain to somebody who is watching and say, no, that one is vaping, is not smoking. The issue of denormalizing is very important. So just to clarify, we did control for the potential confounding from illicit. Nicotine does increase BP. How do we regulate this? The South African SAPRA is there to regulate nicotine, and that's nicotine inherent is regulated as such. However, just to respond again, because we do have smokers, we may want to take that. We may still need to make them accessible, whether NRT, the way we have them as over the counter, for example. The current situation where you have 50 milligram being exposed to a developing brain is untenable. 5% in those disposables is untenable. So you can have a situation still with SAPRA oversight, which means what we call post-market surveillance would then be thoroughly done and enforced, but they do not have to be by prescription. So they can actually get access, just like you have your NRT gums. So it will help smokers. Should industry be allowed to continue advertising? I don't think so. Industry targeting Black Africans, I don't know. But it will look like from history, where we looked at the tobacco industry document, they seem to have been able to use some of those in terms of history documents to target Black Africans. Right now, we do not have current evidence on that, but except that we can see the shift towards Black Africans. What's your relation with Bloomberg Foundation? I don't have a relationship with Bloomberg Foundation. How many papers have you published peer review? Well, I have published about 140 peer-reviewed papers. About 100 of those are on tobacco, and about 70 of those are related to South Africa. So all my studies for the last 25 years has been in South Africa and in peer-reviewed papers, including co-authors of a number of technical report series. Which method is most reliable? There's no one method that you can use to do policy. Clinical research, randomized controlled trials, Cochrane, they're great, but they have their limitations. If you go into those studies, they will tell you this may not extend to all settings. That's why you need confluence of methods to be able to do. When all methods bring you the same result, that's when you decide on policy. So it's clinical trials, population level data, and experimental studies. Hamizan, we need to understand the difficulty of communicating to people who are not scientists to say one is 95%. Even those who are medical doctors will find that difficult. And I think that's the tenets of Hamizan. However, you can talk about reduced exposure that could in next 20 years leads to reduced harm. It will take many years for you to actually see when this reduced exposure would cause what it will cause in the long term. Until then, you need to have the type of bill that we have currently that allows you, by regulation, perhaps differentiate the type of warning that you're going to have on one product from the other product. How effective are vapes? We've already talked about that. Why you need to go to the question about which country we should copy. Sweden is aging population, Netherlands, we should copy the countries in Africa. Yes, it's true, they are different from South Africa. What we're saying, and I showed in that graph, over 40 years, South Africa can copy itself by making sure that it moves back to what it was doing. With good legislation, South Africa was able to reduce tobacco and smoking rate. And I did control for the baseline studies for those countries as well. Thank you.
Last minute.
But in the last minute, I think I should just say that the bill does take care of nicotine. It does not take care of nicotine, but only because it's a nicotine product. However, because it comes from tobacco, the nicotine comes from tobacco, it does somehow take care of that. But we need to be more explicit to define nicotine products. In conclusion, I'm saying that we've had 15 years of experiment with vaping. That 15 years included when there was no illicit. And that period did not show that vaping reduced smoking. I am not saying vaping increased smoking by itself. However, our study has shown that this bill would dramatically decrease tobacco smoking, particularly if you implement 100% smoke-free for obli, which is the 50% of the increase is associated with obli use. If you introduce plain packaging, and of course, support the ratification of elimination of illicit trade protocol and introduce track and trace. Thank you.
Okay. Thank you very much, Prof. And thanks to the colleagues who posed those questions. We will also want you to follow suit if there are any other outstanding issues that were left unanswered properly. Please provide us with that additional information. Honorable members and to those at home who are viewing us from the YouTube and other live streams, we want to apologize that during Prof. Yusuf's presentation, there was 2 minutes that were interrupted, and the lines have now been put back in Parliament, and you can follow. You just lost that 2 minutes, which I've been informed about, but we are now back on live streams, and we would then hope that that glitch has been taken care of. Now, honorable members, drink your water, coffee, tea, and be ready to hear the World Health Organization. We are here where we are as the country. We are trying to follow what they are actually recommending. And it will be very important to get this presentation. And I hope they will also be concise and also give us more information on the clarity-seeking comments. Your 30 minutes starts now. Whoever is presenting from the World Health Organization. So at 27 minutes to 6, we will then stop and give members to ask and interact with your presentation. I hope you are now already given sharing rights. Thank you very much, Prof. You can remain behind if you so wish and listen to the presentation of the WHO. Thank you. Over WHO.
Thank you very much, Honorable Chair. My name is Shanaz Al-Halabi. I'm the WHO Country Office Representative. I have just recently joined here as the WHO Country Office. Are you able to see my screen? I've just been given sharing rights.
Yes. Yeah, just put it on the slideshow, ma'am, if you can. Yeah. No, not that way. Click that hourglass on the bottom. It will then not show 2 slides. It will show 1 slide.
Oh, sorry.
One at a time.
Can you see it now?
Yeah, go further. Oh, God.
Screen. Where are we now?
Yeah, switch.
I'm trying to. Can you see me? No.
We see 2 slides.
Oh, sorry. Fortunately, I'm not able to. Let me see if I can.
There's a go back to where you were before. All the slides on the side and this one big one, and then look for an hourglass image at the bottom of your screen, and then click on.
Where I'm able to just show one screen. I'm not able to do it. I'm not sure why.
Click where you started before, where you were. Yeah, okay, hold on now. Go to the bottom of this big slide and look for something that looks like an hourglass. No, not that one. Go back. No. At the bottom of your slide. Yes. Yeah, okay, let's stay with this one for now because any other challenge is worse than the, yeah. Let's continue maybe. Yeah.
Does this help, Chair? Hello?
We'll wait until we see how we do on the next slide. Yeah.
Okay. So let me just thank you, Honorable Chair, for the invitation for WHO to present our written submission to the Portfolio Committee. We also want to reassure the Honorable MPs of our strong commitment as WHO to supporting South Africa in strengthening tobacco and nicotine control. Nicotine control. Let me just mention, Honorable MPs, that we are talking of saving human lives. This is very important, protecting and saving human lives. Tobacco is the only leading product that kills more than half of its consumers. The second slide it really outlines the presentation. Can you see that? It's not working? Oh, gosh.
I'm afraid you'll spend your time sorting out this slide.
Exactly. So this slide here really talks about the presentation, the purpose of the presentation to highlight the public health impacts of tobacco and nicotine use, present WHO's evidence-based position on the draft bill, showcase alignment with the WHO Framework Convention on tobacco control, and reaffirm South Africa's obligations to strengthen tobacco control as a party to the WHO FCTC. We are witnessing, Honorable MPs, a wave of legal reforms globally and across the WHO African region aimed at strengthening tobacco and nicotine control. Mauritius and Ghana have recently accomplished legal reforms. Tobacco kills more than 7 million people each year worldwide through both direct use and exposure to secondhand smoke. 6 million of these deaths are caused by direct tobacco use, and 1.6 million deaths are due to secondhand tobacco smoke exposure. And I've just heard Honorable MPs talking about people who have died who were not necessarily smokers. Tobacco smoke contains over 7,000 chemicals, many of which are toxic and some are known to cause cancer. While tobacco smoke is inhaled, harmful chemicals enter the bloodstream and spread throughout the body. These toxins damage our organs with both smoking and secondhand smoke, causing a range of diseases, including heart disease, lung disease, and cancer. And these slides are real-life examples. The next slide also shows the different organs that tobacco affects in our bodies and the diseases as well that are related with these particular organs. Then the next slide, I want to just talk briefly on the economic impacts of tobacco use in South Africa. Tobacco use accounts for more than 59.1 billion, or use costs South Africa more than 59.1 billion annually, which is around 1.8% of the GDP. And these costs include direct healthcare expenses for tobacco-related illnesses and indirect losses for reduced productivity, illness, and premature deaths. Honorable MPs, this money could be used to address other unpreventable conditions in the healthcare system. An analysis on economic burden of tobacco in Africa conducted in 2018 showed that tobacco earned the region a combined total of $10.7 billion every year. This amount includes tax revenue to governments, income for farmers, and producer profit. Ironically, the cost of damage due to tobacco use was $21.4 billion, which included direct and indirect healthcare costs and lost productivity. And it really left the region with a net loss of about $10.7 billion, which is about 0.73% of the GDP. And so globally, and these statistics have also been presented and talked about, but you can see that the national survey data from 2021 shows that almost 1 in every 3 adults uses tobacco. Globally, young people in many countries are being aggressively targeted and are increasingly taking up the use of e-cigarettes. And also, this has been also discussed a bit in today's briefings. This trend has been reported to be of great public health concern, and available data reveals that current use of e-cigarettes by school-age children often exceeds those of the older age groups. So in this particular slide just shows that WHO estimates that around 8.6 million adults in South Africa are current users of tobacco. As you can see, there's been an increase over the years. The next slide talks about the prevalence trends in South Africa, and where we are using the SDG 3.8.1 as an indicator for the prevalence of current tobacco use amongst persons aged 15 years and older. And what we are seeing here is that there is a downward trend, but it's too slow to stop the rise in the number of tobacco users. From 2010 to 2025, South Africa is actually at a 7% relative reduction in prevalence, in comparison with the global level, where we are seeing a 25% reduction. And in the African region, we are actually seeing a 32% reduction. And 35 African regions are actually reducing tobacco use prevalence faster than South Africa. Here, you can actually see that the prevalence in South Africa is around the global average and will go above if we don't have a strong legislation. In 2022, it was estimated that South Africa's current tobacco use rate amongst adults was about 20.7%. And this is really more than double the region's prevalence of 9.5%. Both global and African regional averages are declining at a much faster pace than South Africa. So, honorable members of parliament, doing nothing is not an option, as the future of the next generation rests on this. The figures in the previous slide that I mentioned highlight the urgent need for decisive action, and we all have a key role to play. The cost of inaction is staggering. Prevalence would remain above the global regional average. The youth uptake of tobacco, nicotine, and related products will continue to rise. The economic costs, which I alluded to in my previous slide, will also increase and burden the government and the health systems. And then the opportunity for leadership and public health protection will be missed. So passing this bill with strong provisions would position South Africa as a continental leader in tobacco control and will go a long way in protecting our people in South Africa. It will protect our children, our women, the youth, and so forth. And the list continues. So in summary, the draft bill itself is about reducing tobacco and nicotine use, and it requires a comprehensive approach that combines both demand reduction measures with equally robust supply reduction strategies in full alignment with the WHO Framework Convention on Tobacco Control, and as mentioned earlier, which was ratified by South Africa in 2005 and is legally bound by, as well as including compliance with all its articles. So Article 5 of the WHO Framework Convention on Tobacco Control outlines the obligations of each party, including adopting and implementing effective legislation measures for preventing and reducing tobacco consumption, nicotine addiction, and exposure to smoke. These policies need to be protected from commercial and other vested interests of the tobacco industry in accordance with national law. So this actually is the broad definition of what the bill covers, and that has also been discussed a bit in the discussions earlier. The Tobacco Products and Electronic Delivery Systems Control Bill therefore aims to reform the existing law by the introduction and adoption of key control measures, including 100% smoke-free public places, adoption of graphic health warnings and plain packaging, the total ban on the display at point of sale, a total ban on vending machines, and also expanding the scope to cover regulations of electronic nicotine and non-nicotine delivery systems. In other words, the ends and so the next one, the scope of the draft bill, it will cover and protect the entire population, including smokers that wish to quit and former smokers and nicotine-naive youth. The draft also recognizes and intends to address the alarming proliferation of new and emerging tobacco and nicotine and related products on the global market. So the next slide talks about the ban on smoking in all public places, which is the P, or the protect from the tobacco smoke. So Article 8 of the FCTC and its guidelines requires effective measures to protect populations from tobacco use and exposure to tobacco smoke by banning smoking in all public places. In other words, 100% smoke-free public place without any exceptions. And already there are about 79 countries that have adopted this 100% smoke-free protection. In Africa, we have 14 countries that have smoke-free laws, and we are happy to provide more information about these as well. And then the draft bill in South Africa is actually, actually also moving in this direction here. And so WHO supports this exclusion of design smoking areas and the adoption of 100% smoke-free. Then Article 14 of the FCTC, which is as recommended by the WHO Clinical Treatment Guideline for Tobacco Cessation in adults, provides a comprehensive set of tobacco cessation interventions to tobacco users to quit. And South Africa has a national toll-free line where people can call in. But of course, we need to address the costs, which are not addressed in the bill, of covering the costs for people who do want to, replace nicotine. So WHO supports the approach in this particular one, and the green here really highlights, the kind of the affirmative position that WHO has in terms of this legislation. WHO does not recommend the use of unregulated or unapproved products for cessation treatment. And so pharmacotherapy is regulated by SAPRA under the Medicines and Related Substance Act. And there are already several products that have been approved as smoking cessation by SAPRA. Then the next slide talks about the issue on the warning on the dangers of tobacco. So here, what I wanted to just focus on, Chair, is that in the African region, 19 countries have adopted graphic warnings. I think I've jumped. Yes, 19 countries have adopted graphic warnings, and these include Benin, Mauritius, Sierra Leone, and they cover 90% of principal display areas. As of December 2024, based on WHO's 2025 report on the global tobacco epidemic, published in June this year, South Africa only mandates text-based health warnings, covering 20% of the principal display area. So the draft bill mandates graphic health warnings, and the bill specifies that the content, composition, and design of a health warning shall be no less than 65% of each principal display area of package, which is a little bit shy of the WHO recommended one of 85%. So WHO supports the inclusion of graphic health warnings in the draft bill and recommends that these should reflect the current best practices of up to 90% of principal display areas and apply to all tobacco, nicotine, and related products. Then we go on to the next one, which is on plain packaging. So in addition to graphic health warnings, the WHO FCTC guidelines to Articles 11 and 13 encourage parties to consider adopting plain or standardized packaging, permitting only brand and product names in a standard color and format. Plain packaging reduces demand by reducing attractiveness, appeal. It eliminates on package advertising, minimizes misleading branding, and increases the noticeability and effectiveness of warnings. Maybe I should also just emphasize, Honorable Chair, that there's evidence that backs what I'm talking about in terms of the reductions. Early adopters like Australia and UK faced litigation, but they won. And research across countries demonstrates that plain packaging is effective. Globally, 25 countries have adopted plain packaging, including Burkina Faso, Mauritius, and Cote d'Ivoire from the African region. And some countries, as you have seen, have applied this to nicotine-containing products, such as the pouches. In the draft bill, the minister must prescribe standardized packaging for tobacco products, but may prescribe this for tobacco devices, the ends, non-nicotine and nicotine-containing products. So here, maybe I just want to mention that WHO supports retention of plain packaging in the draft bill, but it should apply to all categories of the products. Article 13 of the WHO FCTC and its guidelines for implementation recommends parties to ban the sale of products through the internet, as well as comprehensively ban tobacco advertising, promotion, and sponsorship in all media platforms, including the internet. A ban on the sale and tobacco advertising, promotion, and sponsorship of related and relevant products through the internet is a critical measure to limit access, safeguard use from exposure and uptake, and close the loopholes in age verification. In the WHO African region, 19 countries have banned the sale of tobacco on the internet. And in the draft bill of South Africa, sale through the internet and cross-border advertising, promotion, and sponsorship are banned for relevant products or related products, in line with the WHO FCTC recommendations and with WHO's full support. So a total ban on advertising, promotion, and sponsorship for all tobacco, nicotine, and related products would help close loopholes from deceptive marketing claims. So regarding the ban on display at points of sale, Article 13 of the WHO FCTC and its implementing guidelines recommends banning tobacco advertising, promotion, and sponsorship, including at points of sale. Its guidelines recommend that parties should introduce a total ban on any display on the visibility of tobacco products at points of sale. Ban of displays at points of sale have been shown to be effective in reducing exposure to marketing, reducing impulse buying, helping protect young people from tobacco use, and supporting quitting efforts. In the African region, it's 11. Apologies, in your slide it says 70, but it's 11 jurisdictions ban displays at points of sale. And WHO supports the retention of this provision in the draft bill, which is in line with the FCTC recommendations. Article 16 and the implementation guidelines of Article 13 of the WHO FCTC make provisions for banning sale of tobacco from vending machines. The ban of sale of related and relevant products through vending machines restricts access to tobacco, nicotine, and related products by minors. It helps enforce age restriction to tobacco use, and it really helps to denormalize tobacco use and promotes compliance. And again, in the African region, 31 countries have banned sale of tobacco through vending machines. And so WHO supports the retention of this provision in the draft bill. And this is again in line with the WHO FCTC recommendations. Articles 9 and 10 of the WHO FCTC mandate parties to adopt and implement measures for testing, measuring, and disclosure of the contents and emissions of tobacco products. There is a regulatory clause that the minister could rely upon to make regulations in pursuance of this. And so recognizing that flavors can increase the palatability of products, the partial guidelines of the implementations of Articles 9 and 10 recommend that, that parties prohibit or restrict ingredients such as flavoring agents, which helps to make tobacco products attractive. So WHO supports strong legislation that allows countries to ban flavors in tobacco, nicotine, and related products to make them less attractive and appealing. And then when banning is not feasible, there should be strong regulations restricting the use of flavoring chemicals or agents as constituents and the use of flavor images in packaging and marketing of tobacco and nicotine and related products to reduce the appeal. The regulation of new tobacco and nicotine products, the new and emerging tobacco, nicotine related products such as heated tobacco products, electronic cigarettes, and nicotine pouches are often highly addictive, and they contain flavorings and also harmful additives. All these products contain toxic substances, as has been mentioned already, and pose significant health risks to public health. The tobacco and nicotine industries are constantly targeting children and young people in marketing these products. It is critical that amendments to the law effectively protect the young. Globally, 14 countries ban ends, and 91 additional countries otherwise regulate these ends. So in the African region, several jurisdictions such as Cabo Verde, Ethiopia, they're outlined here, and Uganda, for example, ban the ENDs. WHO recognizes that there's different regulatory goals in different countries, and WHO recently issued a call to action on e-cigarettes, in which it made some recommendations to governments to reduce their appeal and their harm to the population. So, honorable members of parliament, this draft bill regulates the sale, use, advertising, promotion, and sponsorship, distribution, display, packaging, and labeling standards for manufacturing, processing, and importing, and disclosures of related and relevant products, including the ENDSs. While this is in line with the Framework Convention on Tobacco Control recommendations, it could be further expanded to cover all nicotine-containing products, as I've previously mentioned, and that further proofing legislation is important to address the fast-evolving landscape of tobacco. South Africa is a signatory to the WHO FCTC protocol to eliminate illicit trade in tobacco products. And this has also been mentioned by the previous speaker. And I think I should just probably emphasize that we would recommend that South Africa becomes a party to this protocol, and then, of course, implement the measures that are listed below. Then, in terms of the urgency, if I may go into the urgency of the strong legislation, it works if it reduces youth initiation and increases quitting rates. It generates significant healthcare savings in the medium and long-term perspective. It protects the future generations from preventable diseases, strengthens compliance with the FCTC obligations, and also reduces tobacco product appeal and demand. Therefore, the decision you make regarding the draft bill is an important one, as the effect could span generations, affecting our children. Currently, South Africa ranks among the countries with the highest daily smoking prevalence in the African region. This is more than double the regional prevalence. And so to address this high rate of use, the country needs a strong, comprehensive legislation that meets the FCTC obligations and the tobacco control best practices. All tobacco, nicotine, and related products need to be strongly regulated. And so WHO supports these strong measures proposed in the draft bill. And WHO remains committed to supporting South Africa to strengthen even further the tobacco and nicotine control, to fully protect our population, and to address the public health threats of proliferation of new and emerging tobacco, nicotine, and related products, especially amongst the children and the youth. So, Honorable Chair, if I may just conclude by just having this call to action to say that as members of Parliament, honorable members of Parliament, you have a very integral role to play in protecting the health of all South Africans, particularly our women, our children, and the young people in this country, by fulfilling the South Africa's constitutional right to health and its obligations under the WHO FCTC. So the amended bill is a powerful opportunity for South Africa to embrace this leadership role in the African region, as well as globally, as we know South Africa continues to play this leadership role. And we as WHO extend our full support to South Africa in passing the bill without weakening any of its provisions that I've gone through already in the slides, and ensuring that the bill retains and further achieves global tobacco control best and good practices. We need to also timely enforce this because, 1 second, a life is lost. Communicating effectively with the public, and also protecting the children and future generations from all forms of nicotine addiction. And as WHO, we would like to congratulate South Africa for taking this important step. And I thank you for attention, and I'm sorry for the hiccups in the beginning of this presentation, Honorable Chair. With that, I end the presentation.
Okay, thank you very much. Dr. Anita, I'm going to chop your fingers. Okay. Before I chop your fingers, Dr. Anita, let me hear the honorable members who would like to engage with the presentation. Thanks. By the way, honorable members, Ms. Naz has just recently been appointed into South Africa as a WHO. I met her briefly in another meeting. You remember we used to have Dr. Kalua. Now Dr. Kalua has moved up into another office, and Dr. Ms. Shinaz has now come in to replace. So she's a country representative of WHO in South Africa. Thank you very much, Ms. Shinaz. We'll go in the following order. Number 1 will be Honorable Clark. Number 2 will be Honorable Kumalo. Number 3, Honorable Dr. Leroon. Number 4 will be Honorable Dr. Letape. 5 will be Honorable Chirampungose. Number 6 will be Honorable Sine. Number 7, Honorable Motubatse. Number 8 will be Honorable Shabangu. Ms. Shinaz, you keep a pen and paper and listen to all members and you'll answer one time. And the last hand will be that of Honorable Mare. So, honorable members, I think you are keeping your numbers: 1, Clark; 2, Kumalo; 3, Leroux; 4, Letlape; 5, Chirwampungose; 6, Sine; 7, Mutubatse; 8, Shabangu; and 9, Mare, in that order, one after the other. Thank you very much. You can start now.
Thank you, Chairperson, and thank you very much for your presentation. Very interesting presentation, I must say. I've just got 3 short questions that I'd like to ask you. We've had a lot of submissions regarding vapes as harm reduction and being used as measure to stop smoking cigarettes. What are your views on this? Is this as effective as submissions have made it seem to be? Then, in your view, how should vapes and other non-combustible nicotine and tobacco products be regulated? And then what are your views regarding submissions to the committee that banning of point-of-sale displays and plain packaging will strengthen the illicit trade of cigarettes and vapes, considering that the illicit trade in this country hovers between 65 and 70%, which is absolutely horrendous and very concerning to us? Thank you.
Thank you very much, Chair. Chairperson, let me also welcome the presentation by Ms. Shinas. But I'm just having one question, Chair, that I want to get clarity on. On the issue, Chairperson, of presentation by previous presenters, they've reported that there is high level of illicit trade in the country. I want then, Chairperson, to check whether there is track and trace models adaptable to South Africa, and then which countries in Africa have addressed illicit trade, and what would be World Health Organization recommendation? What would be the World Health Organization recommendation? Thank you, Chair.
Thank you, Chair. Thank you for the presentation from the WHO. I have several questions. I think I'd want to start off with the first question being, I think there's been talk about our legislation. There's been looking at and we've had very good, strong legislation for about 20 years now. And the previous speaker as well spoke about our progress flattening out and our numbers going up again. Could the presenter please let me know what you think is the cause of that? It seems like the WHO believes that the solution is stronger legislation, but I think it's important before we do stronger legislation to decide what exactly do we think the cause is so we can deal with the cause. And I'd like to understand what the WHO's analysis is of why our smoking rates in particular have been going up over the last few years. There's lots of criticism of the WHO approach. In the South African context, partly because it's people, particularly around the approach of being not having a differentiated approach to nicotine products, and so there are studies and data showing that if we use a differentiated approach versus a undifferentiated approach to nicotine products, 300,000 lives might be saved. Would you comment on that, please? Why does the WHO not believe in a differentiated approach? And what is your take on the evidence showing that there will be health benefit and public health benefit from that? There's further criticism of the WHO for the snus ban in Europe, and when Sweden got a exception to that snus ban, they have significantly lower rates. Why have those bans in Europe not worked as well as it did in Sweden, where a differentiated approach to nicotine products was available? And why does the WHO regret the fact that it bans snus in Europe and encourage the banning of snus in Europe? I'm very interested in hearing about the illicit trade protocol the FCTC. If you could expand on that a little bit more, it'd be very interesting to hear because I think that is obviously one of the major issues that we have in South Africa. And there's certainly concern that these strict regulations on the legal tobacco sector is going to push even more of our sales towards the illegal stage. And so I'd like to get your take as well. Do you not think that there will be unintended consequences of a very strict rules pushing more people into the illegal side of things? And then finally, what is the WHO's take on the economic consequences, particularly for small businesses and small informal sellers of tobacco, of the We've had people come present and say, like, if they cannot display their wares on a table at a taxi station, they will no longer be able to survive. And so, what is your take on those economic consequences for small business people? Thank you very much.
Thank you so much, Chairperson. Greetings to the WHO. My name is Naledi Chirampungose from the EFF. And my first question to the WHO is in relation to research. Can we say we're at a point where we've got sufficient research to be able to do impactful legislation, especially in relation to product use of vaping amongst young people? I'm lobbied to think otherwise, that maybe governments are not investing enough in the research in the local and domestic and internal perspective and context. And second to that, much of addiction issues is rooted in historical disparities, right? It's rooted in economic inequalities, especially in the context of South Africa with our past that is still lingering in today's day and age. And socialization plays a big part in relation to addiction. And how do we start moving legislation in that direction? How do we use legislation to address issues like that of socialization? Is legislation sufficient? And if it is not, how do we stretch it to be more efficient in its jurisdiction, to affect other tangents that form into socialization in communities, especially marginalized communities? Yeah, thank you so much.
Thank you, Chairperson, and thank you to the presenter. We appreciate the World Health Organization for their valuable insights and global perspective on tobacco control. I'm interested in learning more about the economic burden of tobacco use and the benefits of decreasing tobacco use prevalence. Please provide further details on this matter. Secondly, there are colorful and flavored products wherever one turns these days. And from the data we are seeing in South Africa, with increasing uptake of products like e-cigarettes, especially among young people, what role do you think flavors played, and why do you consider the regulation flavors important in tobacco, nicotine, and related products? Thank you, Chairperson.
Thank you, Chair. Sorry, maybe I was slow to the button. I thought I was number 4. Thank you for the presentation. My first question is, can you just explain FCTC Article 1D has a reference to harm reduction? What is it talking about? And how can we expand on that and benefit on that? The second question is, our Constitution says everyone has an inherent dignity and the right to have their dignity respected. And that includes people who smoke. And it says they have security and control of their bodies. The issue of banning of public spaces, which might impact on that, would you recommend that we change our Constitution to be able to effect that? Because it means that people who smoke have lesser rights. I think the third issue, you spoke about the issue of pouches increasing health risk. Can you just expand a bit on that? And in terms of our bill, we're proposing a monitoring committee, and the minister having powers. The FCTC proposes a national coordinating mechanism. Can you talk about whether we are in tandem with that? Because there would be other people that would be required in terms of getting proper control, the police, finance, taxation, etc., just in terms of how we could coordinate that. That would be all for now, Chair, and I hope there'd be an opportunity to engage more with the WHO. I just want to yield to other members. Thank you, Chair.
No, thanks very much, Chair, and thanks for the presentation from WHO. I must say I will submit written questions because I have so many in respect of the Chair's directive. I'll limit them to just a few. What do you make of the presentation made here 2 days ago, which argued that FCTC does not supersede South African law, meaning the constitution itself? And what has happened to countries that have banned this product, the novel products? And are these products not available in those countries? The third one, how many of the 7,000 chemicals found in tobacco are present in vaping? And the other one, what percentage of the rise in smoking in South Africa since 2015 would say is accounted for by the proliferation of illicit trade in tobacco, from what you have learned? If NRT is so successful as you seem to suggest, why then is this not leading to major decrease in smoking? Why are we seeing the opposite of this? Would you perhaps agree that government has in fact failed in implementing existing laws to its fullest? Thanks.
Thank you, Chairperson. I just have 2 questions, Chairperson. I just want to find out from this 100% smoke-free places, isn't this going to infringe on the right of choice when people have the right to choose what they want to do, to be smoking or not smoking? And then the other thing I would like to ask is the packaging of these flavors. Is it going to have an effect on the companies that is having the brands? How is it going to affect these companies if you say that these packagings of these flavors must be maybe just say it's white? How is it going to infringe on these companies, and what is going to be the impact on this? Thank you, Chairperson.
Thank you, Chairperson. I've got just 2 questions. I think the other one I was covered by the other honorable members who spoke on the illicit trading. Because on your presentation, you mentioned that, the presenters that came here before, they've been suggesting that the banning of advertisement at the point of sale will increase illicit trading. I want to get your opinion on that with regard to what they are saying, that it will increase the illicit trading. And you also spoke on the evidence of effectiveness on the banning of the display at the point of sale, that it will reduce smoking. Can you maybe elaborate more if there are any countries that have taken this measure of banning advertisement at a point of sale? I would appreciate if maybe you can elaborate on this, comparing or talking to the countries that have taken these measures, the countries that have similar social economic status to ours, so as we can understand the effectiveness of banning the advertisement at the point of sale. Thank you, Chair.
Thank you, honorable members. Ms. Shinas, from my side, we welcome your support on this because most of the things we do on any of our health programs, we use reference WHO and check what are you saying on this and that. And therefore, I think this also, as a league, is assisting us greatly. I do not think we will have, I don't know, pressed by time, have another opportunity to listen to WHO on this bill again, though it might be interesting because you are like the World Authority on Health. This bill is about health and is pro-health. So if time allow, we may just come in and share with you more. But if there are any things outstanding from this presentation in terms of responses, please do share with us those here. I have an opposite to what Dr. Letlap was asking because I've experienced smokers who never bother to ask anybody around them whether can I smoke. They just think that it is their opportunity to smoke, irrespective of whether the people around them do like to smoke. So their access to this free health, to the free space is very is very circumspect because they must also respect that there are people who are totally allergic to their smoking. And therefore, if you actually were to say you are doing this to strengthen those rights of the people who are not wanting to be secondary smokers, was I dare wish to see any smoker who before smoking will ask anybody around them whether can I light a cigarette or not, because we'll tell them no, go across the road, don't do it here. But secondly, there has been some presentations here and people arguing that maybe we need to halt such programs and deal with the country's illicit trading. And want to hear from you with your world knowledge, if there's any country that has not really come in to strengthen the tobacco control bills, waiting for its improvement on illicit, and has then been successful to say we are now at an acceptable level of reducing illicit trading, only then we can introduce such measures. Thank you very much. We will only limit you to 12 minutes. So you would probably by 10 past 6 be wrapping up. That would be 15 minutes. Thank you very much, Ms. Yes.
So thank you very much, Honorable Chair. With your permission, Honorable Chair, WHO is made up of 3 levels. We have the headquarters, we have the regional office, and then we have the country office and also the expert working groups as well. So we are the entire tier is in this call here. So we've aligned ourselves to actually respond to the different questions. So with your permission, I'll ask Professor Ghazi to maybe respond to a few, and then we'll continue that way. Thank you, Chair.
Hello, can you, do you hear me?
We can hear and see you, yeah.
Okay,
thank
great.
you.
Thank you for being part of this discussions, and my greetings to the honorable members of the parliament. This is an honorable opportunity for me to address on this very important topic. I'd like to take the question on, where does WHO stand regarding human harm reductions? I think this allegation that this is a prohibitionary approach by WHO is not a true statement. I think this is contrary to the fact that WHO always strives to ensure that there is not only harm reduction, there is harm elimination. And many of these products have been put into the market with false pretensions. And I think my Dr. Yusuf have nicely outlined the definition and our approach in harm reduction to the notion that we look at it as applied to a population and to specific diseases and disorders which pose a specific health condition. So this does not apply necessarily to smoking, as we just smoke present a health hazard and health harm, but these new products and the way it has been somewhat the narrative taken up by the industry has shifted the discussion into a theme that is contrary to the intention that WHO has been working all along. WHO has been burned before with all these notions of new products coming in with, light and reduced risk, etc. in the past. And only with time we realized that all these false claims proved to be wrong. It turned out they did not reduce the risk of cancer. They did not reduce the risk of cardiovascular disease. They did not reduce the hazards on a pregnant woman. They did not reduce the risk on children. So we have been burned once, and that's why we're not rushing to the notion until we have to harm reduction, until we have the evidence. We would like to see where is the evidence that these products are indeed serving the purpose of reducing harm to individuals, be it in the level of all these parameters that we know that have been established and associated with tobacco use, be it the traditional conventional products as well as the more recent products. So this is where the dilemma is. And we'd rather see us united in trying to counter the effort of the industry to shift the paradigm in its favor, because that's what they want to see, that, we're divided on this. Let me tell you about, some of you have already mentioned about the number of toxins in the cigarette smoke. But we're starting to realize more and more there are these toxins that exist in these newer products. And we didn't have yet the test of time to see how they will impact the lives of people. And, and we should not be focusing the discussion only on cancer. There's by far the injury to these products on the respiratory system, the cardiovascular system, the pregnant woman, children. I don't want the discussion to be focusing only on cancer. I'm a pathologist, and I diagnose cancer every day. But I would like to see myself is trying to do away with the harms of tobacco as well as these new nicotine tobacco products. There was a question came up about nicotine. Nicotine is toxic. Some of these nicotine pouches, they have up to 30 milligrams of nicotine in them. Some of them even have 50. If you just, I don't like to compare, but just to take an example, a cigarette will give you only 1.5 milligrams of nicotine. So can you imagine one pouch exposing a child or an adult to 30 milligrams of nicotine? And the new products that have been introduced into the new kind of nicotine that have been introduced into these products, the salts that some of them have alluded to earlier, also they somewhat camouflage our ability to do this regular testing and regulation. So that's why I think we have to be careful, we have to be cautious. And a cautious approach does not mean that we're against a harm reduction. It's just simply we have to have the evidence. We are a scientific group. We are a group of people who want to see the evidence before we start advocating. We're not opposed. As a matter of fact, in some of our work at I'm the chair of the study group on tobacco product regulation. We left the door open for the use of these products for a specific purpose, but it has to be linked with an overall plan. The Scandinavian countries, Sweden, including the snus, it was not only an isolated item of a tobacco product, it was a comprehensive tobacco control. There is a room for these new products to be part of a comprehensive tobacco control measure, not isolated. If the industry is genuine about helping us in the public health care sector, for God's sake, why they keep producing 20,000 flavors? If they are genuine about protecting children, and that's why you're seeing the rise in South Africa, because they keep pouring these flavor products that makes it attractive. The design features make them attractive. And the flavors, by the way, is the most effective way to initiate the use of these products. Not only that, they also potentiate the effect of addiction. And they are also, why they are the primary use by these. And as a matter of fact, if you look at the recent data from the Netherlands, for example, which the Netherlands have taken the step to ban flavors. And they have witnessed 40% drop in the use of e-cigarettes only by banning flavors. And by those who were surveyed, 22% of them, they said attributed this to the flavor. So flavor is something that's going there and interplay with the other factors. So that's why we're taking this very cautious approach, judicious approach that we would like to base on science. Let the industry prove the evidence that these are effective cessation tools. Let them prove these are effective in helping people quit. As a matter of fact, if you look at the data carefully, and some of this was already presented by the earlier presenters, many of them, they continue to be dual users. That is, they're using the conventional cigarettes as well as the e-cigarettes and other HTPs. So that's why we're trying to be careful in assembly. As a matter of fact, also the heated tobacco products, there is evidence of combustion. They're far from being no combustion. We have also, but several papers have documented there is combustion. So the story is not straightforward, and that's why we urge you to use this information in order to come up with a very robust, strongly worded bill that will protect the children as well as the adults, not to fall into another trap and to find ourselves later on regretting that we have adopted these and rushing to adopt them. So that's why I just wanted to make this statement, and I'll be happy to answer any questions from the group, and I'll turn it over to my colleagues. I don't want to use all the time. I know we have a very tight period, but hopefully this information will be useful in order for you to carry on with your discussion and deliberations, which I have to commend you for them. And this shows a lot of responsibility on the part of you as protectors of the citizens of South Africa.
Yeah, back to you. Back to you, Ms. Smith.
Good
Hello.
afternoon. William, go ahead. Sorry.
Yeah, can I take on the next question? There was a question on point of sale. It's a proven measure with a lot of evidence that it actually works because it's a promotional tool, and a number of countries have successfully actually banned this and even shown to work. France, Ireland, and Norway. In certain cases, there's a reduction of 7% of tobacco use, especially among daily smokers, when these measures are implemented. And also it avoids impulse purchases, and this has been proven again with a lot of evidence that can be shared. On illicit trade, yes, the technical requirements for track and trace models are provided for under Article 8 of the protocol, to which you are not yet a party. But a number of options are available to countries. And again, this is depends on the country. WHO does not recommend which provider should develop track and trace for a country. And of course, we know that the industry attempts to push some of them, like Codentify, to try to capture countries' regulatory measures so that it favors them. But WHO does not take that decision. It's for a country to do it. But there are best practices of countries successfully adopting track and trace measures in Africa, like Kenya, Malawi, Ghana, Rwanda, Uganda, Senegal, Cote d'Ivoire, Gambia, and Sierra Leone. Of course, globally, we have many best practices like Turkey, Brazil, and Canada. Really, the recommendation the WHO gives for a country that's not a party, because Article 15 is in the WHO FCTC, and it requires countries to take measures to tackle illicit trade, even without becoming a party to a protocol. Recommendations include, for example, adopting an effective and secure track and trace measures system, licensing all supply chain actors, securing marking tax stamps on all nicotine-containing products, and a coordinated multi-agency enforcement framework. I just wanted to turn to some questions on constitutional rights. I think South Africa, you've got a very good tradition of constitutional rights. And
You had limited all your responses to 10 minutes.
hello? Okay, can I sum this up quickly, Honorable Chair?
As your last speaker, thank you very much.
Okay, I'll let my colleagues take on then. Thank you.
Perhaps if I have a moment to make a last minute comment.
Yes,
My name is
yes,
Mark
yes.
Goodchild. I'm a tax economist for the Fiscal Policies for Health team. I just wanted to highlight what we spoke about illicit trade here, that in fact highlight that illicit trade is present in all countries around the world, really, regardless of the tax levels that are in place. When we look at levels around the world, we typically see illicit trade in the order of 10 to 20% of the market. And so when we see high illicit trade, higher amounts on that, we can see there's really some kind of deliberate problem beyond tax measures and tobacco control. As my colleague had mentioned, there are clear measures to address this, and WHO recommends ratifying the illicit trade protocol. Already there are 69, 70 countries that have ratified the protocol. This is not just a measure of solidarity, if you like. The protocol contains many measures that will help tackle the different aspects of illicit trade. And we have had examples here of the track and trace system from 9 countries in Africa that have adopted this system, including an early champion here at Kenya, who have a digital tax stamp system that has a unique identifier. And this is something that South Africa could adopt early on as well, as this is a way forward to have ultimately a track and trace system. But there are other measures that focus on enforcement and investment in border enforcement and regional cohesion. If I have the time to continue, I just noted there was also some questions raised about the economic impact of tobacco control and taxation measures.
You will have more time to write to us the additional information that you do have, which will very much, but we will not take it longer than this. Please do write to us those outstanding comments. Thank you.
That would be my pleasure. Thank you.
Do you have any last word from you, Ms. Shinas? Okay. That was the last
Honorable Chair, I just want to thank you once again for the opportunity as WHO to have made an oral submission. There were a number of questions that we have not been able to answer, but we will provide a written submission. And if, with your permission, at some stage, we'd be happy to come back and present on any particular issue that you would like us to present. But really, thank you for this opportunity.
Thank you very much. We look into that. There's a strong possibility that we might really force ourselves to listen to WHO again before we wrap up on the bill. But we look at our schedule and really indicate to you timelessly whether we will have such another opportunity. Thank you very much. And we are released, but we can stay for another last presentation of the day from the Cancer Association of South Africa. If Ms. Makalamba can allow the presenters to stop sharing rights, and then they start their presentation now. If they finish at 7.
Sorry, I can't hear you. Sorry, Chair?
Yes.
I can't hear you. You are very soft.
Yeah, while I'm soft, you can hear me. That I'm saying we'd like to have the last presentation now on Cancer Association of South Africa. Their presentation starts now and finishes at 7.
Okay, noted. Thank you. Good evening. My name is Lorraine Govender, and I serve as the National Manager for Health Programs at Cancer. I am a registered nurse by profession with 19 years of dedicated service and experience in cancer. Co-presenting with me this evening is Menenhle Dlamini, a dedicated social worker who works extensively in the field of tobacco control. I'd like to state that we are in support of passing the Tobacco Products and Electronic Delivery Systems Control Bill. Thank you, Chair. I will now share my presentation. I'm gonna try to do it. Okay. Hope everyone can see it. Fine. Okay. About the Cancer Association. So we are a leader in the fight against cancer in South Africa and established in 1931. Yes, over 90 years of experience in the field of cancer. The vision of the Cancer Association of South Africa is to lead South Africa towards a cancer-free society. Our mission as a nonprofit organization is fighting cancer. We enable research, educate public, and advocate for and support all people affected by cancer. Our vision is to be leading South Africa towards a cancer-free society. So some of the highlights, sorry, Chair, I'm just going to put my video off because my network is not good. I'm presenting from my residence. So some of the highlights in terms of cancer's history in the tobacco control space. So cancer's partnered with the National Council Against Smoking, the Heart and Stroke Foundation of South Africa to establish the Tobacco Action Group, which was named TAG in 1991. And TAG has always been at the forefront of securing tobacco control legislation in South Africa. One of the highlights that's worth mentioning, cancer was awarded the 2009 World No Tobacco Day Achievement Award presented by the World Health Organization in recognition of cancer's accomplishment in the fight against tobacco use in South Africa. Sorry, I think I'm stuck here a little bit. Sorry, Chair, but my slides are now. Okay, I'm just going to stop sharing and share again.
You're taking your time. You're chowing on your time.
Sorry. Okay. No. Sorry. Just going to change and share again. Okay, I'm just going to use this format to present, Chair, because nothing's doing here. Okay. Sorry. So just checking if y'all can see my slides now. Hello?
Yes, okay.
Okay. Okay. Thank you. So I want to focus, the Cancer Association, given the background that we are in the healthcare field, we would like to focus on the health harms of tobacco use. So the use of tobacco causes disease, disability, and leads to untimely death. Tobacco use is one of the major risk factors of non-communicable diseases, such as cancer, heart diseases, stroke, lung diseases, and diabetes. Globally, tobacco kills over 8 million people each year, and 1.3 million are the results of non-smokers being exposed to secondhand smoke. In South Africa, over 32,000 people die from tobacco-related illnesses each year. Tobacco is the leading preventable cause of cancer. So imagine that, something that can actually prevent cancer. You know, when we talk about cervical cancer, we want to know how can we prevent cervical cancer? And we know we have the HPV vaccine. Similarly, when we think about cancer, we can think of tobacco and how can that be eliminated in order to decrease the incidence of cancer. So tobacco use is responsible for more than 15 different types of cancers. Smoking is the leading cause of lung cancer. So often when we think about cancer, we only think about lung cancer, but I'm not sure how many of us really know that it's responsible for over 15 different types of cancers. Cigarette smoke has more than 7,000 chemicals, and among those, about 250 of 250, 70 of them are harmful chemicals and contain carcinogens, which can cause cancer. So every time you breathe in that smoke or are exposed to it, those chemicals then enter the bloodstream, which then carries the chemicals to all parts of our body. It also weakens the immune system and puts us at risk to many other diseases. And therefore, it makes it harder for our body to kill cancer cells. When this happens, cancer cells can grow and spread. Now, just looking at this diagram, it looks very colorful. So in orange are the cancers, and in blue are the chronic illnesses. Now, looking at this picture of the, that we see in front of us, there's almost no place where we can see in our body that's not affected by tobacco. Just looking at it, looking at the cancers, head, neck, throat, and mouth, lung, leukemia, stomach, kidney, pancreas, colon, bladder, cervix, and the list goes on. And looking at the chronic illnesses, stroke, blindness, gum infection, aortic rupture, heart disease, pneumonia, hardening of the arteries, chronic lung disease and asthma, reduced fertilities, and hip fractures. So yes, it's quite a lot to take in. So just looking at smoking and people diagnosed with cancer. So just looking at the article that I have a screenshot of, some of the key takings from this: smoking increases the risk for developing other smoking-related cancers. So this is in particular to people who have been diagnosed with cancer and are still continuing to smoke. It increases the risk of cancer recurrence, cancer coming back after treatment. It can result, well, actually, the research shows it results in poorer response to treatment, and it can result in treatment complications and side effects. Secondhand smoke and its impact on health. So again, the article, yes, that has been done in South Africa by some of our esteemed colleagues and partners that are here today on the call. The key findings from this research shows in our country, exposure to secondhand smoke increases the risk of getting tobacco-related illnesses, such as non-communicable diseases, cancer, stroke, heart disease. Yes, Cancer South Africa aligns to international incidences as well. So, when we talk, we're not only talking about international trends. Yes, research that is local. So exposure to secondhand smoke is high. About 47% of non-smokers are exposed to secondhand smoke. That is amazing. That's a huge figure. There is no safe level of exposure to secondhand smoke. Even brief exposure can cause immediate harm. Just looking at cancer deaths, 43,600 people died from cancer from 2008 to 2019. That's the stats essay. Imagine that. People from households, people, mothers, fathers, children, those are the people that have been affected, that have passed away as a result of being exposed. So although we know childhood cancer is not due to environmental causes, but definitely looking at the adults. While the overall mortality decreased from 553, that is 24.1% in 2008, 454,014 in 2018, deaths due to cancer increased from 33,720 in 2008 to 43,613 in 2018, 29.3%. So from 2008 to 2019, lung cancer contributes the highest number of cancer deaths in men and the third leading cause of cancer deaths in women, according to Stats SA. So again, showing us that although the mortality rate decreased in terms of exposure and cancer, we also show an increase in terms of cancer deaths, specifically cancer deaths. So smoking is the leading cause of lung cancer, and we all know that. So I'm also going to share with you, and I hope, Chair, that this will be able to play. We have a story from a patient, and I hope you can hear the story. Thank you.
Can't hear, Chair.
Oh. Okay, sorry about that. Just 1 second. Okay, Chair. Hello.
I take it that you keep this conversation to yourself before bringing it to us, so you know that it works.
Okay. All right. I'm going to go on, Chair, for the purpose of time. So basically, Mr. Toby is talking about his experience as a lung cancer patient. He talks about being exposed. He started using tobacco products from the age of 16. He also talks about losing his wife to cancer. And he talks about his experience currently and his concern about the youth that are smoking and, how he encourages them not to smoke. So those are just some of that's just his story about, his experience. So we just thought it would be good to share a survivor story here, but I take note that you can't really hear that. So I will continue. So Mr. Toby's story is not rare. It's one of many. It's one of many stories that we come across at the Cancer Association. The bill would definitely prevent people like Mr. Toby from getting cancer. So, thank you.
Greetings, honorable members. As a health organization, Cancer Association of South Africa, and also in our attempts to try and reduce the cancer incidences in our country and lead South Africa towards a cancer-free society. This proposed bill is very important to us as it will help reduce tobacco use. It will help prevent children from starting to use tobacco products and electronic cigarettes. It will also protect non-smoking and vulnerable populations from exposure to second smoke and aerosol, and that will help save lives. So I'm just gonna briefly take you through some of the key provisions that are proposed by this bill and also explain why we support them as a Cancer Association. So starting with the first one, which speaks about indoor public places and certain outdoor areas that will be determined to be 100% smoke-free. Now, this provision is very crucial in protecting people from being exposed to secondhand smoke. It will also reduce exposure to carcinogens for non-smokers as well. It will also encourage smoking cessation. Smokers may be more motivated to quit smoking when smoking is no longer allowed in indoor public places. It will also help in terms of promoting healthier environment as well. Now, on my right, we also have an article that shows the success of smoke-free environment in Australia. And also they mentioned that not only have they directly contributed to the significant reduction in smoking prevalence, but also and reduced individual consumption of tobacco products, but they also gained a widespread community support. You are muted, Lorraine.
Sorry, so sorry. Okay, sorry about that. Yeah. So I just want to share with you, this is a screenshot of what we have on our website at Cancer. So we know that there are many people, a lot of the public want to know, where should they go to, should they have problems. So when we talk about the problem, the tobacco issues in society, we also want to share with you some of the complaints that we get from the people. So it's just not hearsay in terms of what we talk, but this is real complaints that we get and what the public are faced with. So on our website, we do have information on where people can go. And enforcement continues to be part of the work that we support. We believe that this bill will make enforcement even easier. We have several incidents where we've had to support citizens that had a problem in terms of issues around tobacco exposure to secondhand smoke. So if we look at the screenshot here, and I just want to read it quickly, the person that's complaining says, in one of the houses, there is someone that is smoking, and after many requests, this person does not want to quit smoking in the house where a resident with cancer will also reside. So basically, the person that's complaining is saying they have cancer and they are exposed to secondhand smoke because of the home that they're living in. So this could be, a place like a frail care facility and things like that. So what we do at Cancer, we then escalate it to the Department of Environmental Health, who then investigate the problem, and they would send someone out to really go and visit the client and look at what's going on, what are the compliance issues, and even take it up further from there. And here is another public concern. The person here says the smoker next door to me is still refusing to stop smoking on the shared balcony and stairway. Body Corp sent a letter to the owner, and the owner also does not know how to proceed given that the tenants are refusing to stop smoking. I have also approached the local councillor in my area, and I've been waiting to receive a contact where I can report the smoker. I have done some reading, and it sounds unfair. As I am a complainant, have to do what I have to do is to prove that the cigarette smoke is a nuisance and to get the smoker to stop smoking around my flat. He smokes outside to protect his family and has no regard for mine. So again, this is just another example of the complaint. Thank you.
No, the provisions on that speaks about the banning of the sale of cigarettes through vending machines is also very important because the industry has also used vending machine as advertising tool. They've exploited this loophole and gap to aggressively promote their product to people as well. And the other problem with vending machine is that it's also easy access to tobacco products and electronic cigarettes by children as well. So banning the sale of tobacco products, including electronic cigarettes, will also help prevent minors from easily accessing these products. It will also help in terms of reducing impulse buying. And then also prevent youth initiation as well. Again, here we have an example here, UK, which has already adopted similar measures where they have already prohibited the sale of tobacco products through vending machines, and also took it a step further as well, and also banned display of tobacco products in shops as well. So again, this is proving that other countries out there are already adopting similar measures that also we're fighting for in our country, in trying, or in their attempts of trying to help reduce tobacco use and also protect minors from easily accessing some of these products. Next slide, please. This one speaks on the ban on display at point of sale. It's similar to the previous one as well. This will help reduce, again, impulse buying. Also, will shift the social norms, making tobacco products less visible and promote a culture of non-smoking, and also which will help in terms of denormalizing tobacco use as well. And importantly as well, it will also help encourage those who are trying to quit smoking, and also will seize again the gap or the loophole that is exploited by the industry by using point of sale to also advertise their product. Again, here we have research that is showing the tobacco product display at point of sale expose youth to pro-tobacco messages and create a positive attitude towards tobacco products and brands. And also there was a survey that was done in New Zealand, here on my right, that where they interviewed former smokers to find out if point of sale display of tobacco products encourage impulse buying among people who are trying to quit smoking. They found out that tobacco displays had high visibility and elicited physical and emotional reaction that created ongoing temptation, stimulated impulse buying, and caused them physical and emotional cravings that made quitting more difficult. Participants strongly supported the banning of tobacco retail displays, primarily because they thought this would also reduce youth initiation and assist those who are trying to quit smoking. And then when it comes to plain packaging again, the biggest problem that we have currently in our country again is that the only warning we have in some of the cigarette packaging or tobacco product packaging is only the textual warning, which only covers about 15 to 20% of the back and front of the packaging, and also not visible enough. Therefore, it is not effective in terms of educating people, raising awareness about the harms that are associated with using these products. So having plain packaging with more pictorial health warnings that will help in terms of reducing the appeal and also reducing their attractiveness, especially to younger people as well. So again, we have an article here that speaks about Australia as one of the countries, again, that has implemented or adopted similar measures. And then they're also saying that here that they have also benefited from introducing plain packaging, which has also helped to significantly reduce smoking prevalences in their country. And here we have the WHO Global Status Reports that also mentions that the objective of having plain packaging is basically to reduce the attractiveness of tobacco products, eliminating tobacco packaging as a form of advertising and promotion. Advertising and promotion is one major way of getting people to continue smoking and getting young people who do not smoke to start smoking as well. Also, the objective is to eliminate misleading information by addressing package design techniques that may suggest that some products are less harmful than others. Here in South Africa, again, just to use this as an example, we still have a lot of young people who believe that smoking hookah is less harmful than using traditional or conventional tobacco products, just because of the flavor and also the packaging of the flavor that is used in hookah pipes. And then lastly, the objective is to increase the noticeability and effectiveness of health warnings. And then the last one, which speaks about the regulation and control of electronic nicotine delivery systems and non-nicotine delivery systems. Again, here, this will help prevent vaping as a gateway. It will reduce the access of electronic nicotine delivery systems and can help younger people, prevent younger people from transitioning to smoking regular cigarettes. It will also minimize the long-term health risk. Again, while e-cigarettes may have fewer harmful chemicals compared to traditional cigarettes, they still pose a significant health risk, including nicotine addiction, cardiovascular diseases, asthma, and more. And we see that already what this bill is proposing, by proposing to regulate and control these products, the bill is taking a precautionary approach by regulating or proposing to regulate to the extent that the evidence keeps evolving. Some research again suggested nicotine can damage the cell DNA, which could lead to mutation that contribute to cancer development. Therefore, again, as the organization, we are in support of the regulation and control of these programs. And then here, this is also an article shows a study that was conducted here in our country, South Africa, that speaks about the association between electronic cigarette use and quitting behaviors among South African adults. So the key takeaway here from the study is that e-cigarette use, while associated with higher likelihood of quitting short-term, it was associated with the lower likelihood of long-term quitting and higher likelihood of smoking relapse among ever-established smokers who had tried to quit using electronic cigarettes. So this shows again that at a population level, trying to quit using the electronic cigarettes may not be as effective. And then these are just some of the problems that we have in our country when it comes to vapes as well. Here, this is a picture that shows one of the schools in Gauteng where the SAPS members visited the school and conducted a search operation. So a lot of the learners were found with these products. Also, assuming that majority of the learners in high school are below the age of 18 years. So we can already see here that since these products are not regulated and controlled in our country, they are also easily accessible to young people as well. And even when you see some of these products, the way they look with all these nice, beautiful, attractive colors, some of them, they even look like ordinary products, that are used in schools. Products like your highlighters, products like your USB flash drives, your pens. So if you just by looking at this picture, if I were to place a highlighter here or USB flash drives, it might be very difficult to separate the two. So therefore, you can tell that maybe if the learners are bringing these products to school, it's a bit difficult for teachers as well to detect these products because of how they are designed and look. They can be easily concealable as well. So again, we are in support of the regulation and control of the electronic cigarettes. And then the previous speaker have already spoken on this one again, the harms of nicotine, because other speakers have been mentioning that nicotine is not harmful in a way. So again, here we are trying to show that nicotine is actually harmful because it's highly addictive and also contributes to diseases such as your cardiovascular diseases and respiratory diseases. And then in this article here, they're also showing that proving the harmfulness of nicotine as well. So especially to young people as well, when they use some of these products that contain nicotine, they also get addicted to some of these products as well, such as vapes. And again, the previous speaker also mentioned that their brain development still is also can be affected when they are exposed to such products. And then here again, here I'm just going to talk briefly about harm reduction. Again, we've seen speakers here that have been proposing using vapes as a harm reduction tool. This here, just trying to remind us that harm reduction is not a product. It is actually an approach, and also while there is no single definition, we must be clear that harm reduction has been co-opted, narrowly defined by the tobacco and nicotine industries to serve their own interest. They've reduced it to a marketing tool, equating harm reduction solely with the availability of alternative products like your e-cigs and your heated tobacco. This is misleading and incomplete. Harm reduction includes policies to regulate and control electronic cigarettes and all nicotine products, especially to prevent initiation and long-term use. Measures to reduce secondhand smoke and also exposure, protecting non-users from increased risk of cancer, heart disease, and other
During your last minute now. Thank you very much. During
Okay.
your last minute.
Oh, so basically what you are trying to see here, this bill also is very important in terms of helping us reducing.
Sorry. Okay, thank you. So Chair, I'm just about finishing. So I just want to talk about, so we know when we talk about
you have exhausted your time. You have exhausted your time. You are not about to start a new topic. You have exhausted your time.
Okay. All right. Noted, Chair.
Just wrap up now.
Okay, thank you. So in conclusion, we say by implementing these measures, the proposed bill has the potential to make a significant contribution to reduce cancer incidence and improving public health in South Africa. So thank you so much, Chair.
You have been with us, ma'am, this whole afternoon. There are certain slides you repeated, which were given by the other presenters. You could have just said, I concur in my slide with the presenter that talked about so many people exposed to a secondary smoker. So you could have made up your own time. Right now, there have been 10 slides were repeats of other presenters and are similar to yours. You could have saved your time by just doing that. But you don't mean that we should have a world that is without, because you are saying smoking causes cancer, smoking causes lung cancer. Now you should offer the world something else, because there will always be people who want to use nicotine. The nicotine use, we're not going to do away with it. So I probably understand it was not within your scope or your space to talk about other things, because this bill is about tobacco control and other electronic, strongly so, electronic delivery systems. So, of course, I'm not complaining, I'm just raising that your 45 minutes, was largely on tobacco, smoking, and what it causes. And this bill has other things that it talks about other than smoking. But anyway, let us leave it at that and then ask honorable members to comment on your, and then the hands have started coming up. The first one was Dr. Etlape. The second hand was of Kumalo. The third hand was that of Shabangu. Fourth is Mutubatse. May I just get all the hands one time so that we one after the other? So please, honorable members, note your time. When the other member finishes, you come in. Dr. Letlape, you are number one. Honorable Kumalo, number two. Honorable Shabangu, number 3. Honorable Mutubatse, you are number 4, in that order. Thank you.
Thank you, Chair. My first question relates, we've just had another cancer expert, a clinician present to us, who says there's evidence that substantial reduction of carcinogen exposure will reduce risk of cancer. You've spoken about the plus 7,000 chemicals that are in tobacco smoke that are substantially reduced in alternatives. What is your opinion on that? You support the issue of banning of public spaces. And I'm just intrigued by the example that you give of a person that is smoking in the patio and the neighbor is complaining. So with this bill in its current form, they would be able to, that would be a criminal offense and the cops can come in. Where are you suggesting that smoker goes? Because we've had evidence that has been led here that more than 60% of the people that are diagnosed with cancer will not stop smoking. So should he be going back into the house, smoke inside his house, or throw everybody out of the house so that he's smoking alone? Well, in this violent society where children are beaten up for different things, what do you think is going to happen in that family? So we're coming with something that does not take a reality into account. We have informal settlements where a house is on top of a house. How do you suggest this that you support should be legislated upon? Where should smokers go? And do you support harm reduction? Do you think that people who have cancers, who smoke, who can't quit or choose not to quit, are entitled to other alternatives? Nicotine pouches, there's no, or tobacco pouches, there's no smoke. But in the way this bill is structured, even those would be thrown by the wayside. Is that the position of the Cancer Association of South Africa? Thank you, Chair.
Thank you very much, Chairperson. Chair, let me take this responsibility time to welcome the presentation from Cancer Association. But I'm just having one question, Chair. In one of your slides, you have shown vapes confiscated from school, yet e-cigarette companies claim that they do not sell to children. Then my question, Chair, is how will the bill contribute to stopping youth access beyond just banning under 18-year-old sales? Thank you, Chair.
Thank you, Chairperson. In this presentation, it is more on the public health and protection of public from the fatal harm by the smoking. I just want to check with the presenter if the bill is providing sufficient measures to protect the public health against these fatal outcomes caused by smoking and vaping, because it's both products. And again, on your work that you are doing, what kind of policies are you expecting the government to put in place to support your work? Thank you, Chair.
No, thanks very much, Chair. In your presentation, let me start off by welcoming the presentation. Would you say that the Tobacco Product Control Act has been fully implemented by successive governments? If so, why has South Africa's smoking rate increased since 2010 and 2012? Secondly, what is the percentage of this smoking increase would you attribute to widespread availability of cheap illicit cigarette? What cancers are caused by vaping? Does nicotine cause cancer? Just a direct question. The other question would be, if exposure to lower levels of carcinogens is better, We heard from the oncologist earlier on and IRSC that substantial reduction into carcinogen exposure will reduce the risk to cancer. What is your take on that statement? How many quit clinics does the South African government run, and how successful would you say these have been since the adoption of the Tobacco Control Act? Yeah, so those are the few questions that I want to put in place. Thanks, Chair.
Okay, any other honorable member?
I was cut off from the internet for a second, so I wasn't around when you opened for questions. But I wonder if I could ask one or two questions too.
After Dr. Leroux, any other member who also was forgotten or left out? Okay, come through, Honorable Leroux. Thank you.
Thank you very much, Chair. Thank you for the presentation and thank you for the work that you do as Cancer. I think that you have an important role, and I just had a few questions about your presentation. I think that I was surprised. I do, in the examples you gave, I do understand to some extent why you say that enforcement will be easier. But I think that what is interesting is it just seems like currently we are struggling to enforce the laws that are in place really, certainly around illicit trade. And it seems like a whole lot more things that police have to enforce will become available. And so I'm surprised that you say that it's going to make enforcement easier. I think it's going to put more of a burden on the police and on law enforcement. So I just wanted to hear your perspective on that. I was wondering just around the
Dr. Leroux. I don't know whether it's my phone that has frozen.
No, it's all
Not
of
you,
us.
Chair. Dr. Leroux has disappeared. He's frozen.
Okay. Thanks. Okay, let's wait for him to come back. While we do wait, may I ask my other questions, two of them? Cancer Association has been with us in most of the public hearings. There's been a wide criticism and a cry that this and that done will increase illicit trade. What's your contribution towards that story or reducing the illicit trade? Now, you also would probably, in support of the bill, talk to what regulations we should do for vapes. There's been an assertion by other people that the more expensive the vaping machine is, like the one that is multiple use, the better it will be for us as a country, because the young people will not be able to access that one. The single use are much more easily accessible by young people, and also they have an environmental impact that is not that is adverse. I'm just probing this because your presentation was very scanty on these issues that we have to allow in the country. We will not completely ban everything. We have to regulate, but it would be nice to incorporate your thinking on them. Those are my two. But Dr. Leroux, are you back?
I am back. Thank you, Chair. I'm sorry. I don't know what happened with my connection there again.
Okay.
I just have two more questions quickly. Thank you very much. I think the other questions were just around the presentation in terms of the vaping, and you spoke about concerns around cancer and concerns around vaping as a gateway. And again, although I support your fight against cancer and your strong opposition against tobacco use, I just feel like it undermines your presentation somewhat because I don't see very strong evidence for vaping. There doesn't seem to be much evidence that vaping causes cancer or that it is the gateway for smoking. And so I'd just like you to comment on that, please. And then, yeah, I think that's all from my side. Thank you very much.
Okay. The presenters will give you up to, we have given you 2 more minutes. We'll give you up to 10 past 7 to comment on these questions raised by honorable members. Thank you very much.
Thank you, Chair. Yeah, okay, so I want to just sort of group some of them. I don't have answers to all of the questions, but I will submit to the committee the responses. I just want to start off by saying tobacco control enforcement is not policy, but creates a different social environment and it's social policing. The illicit cigarette issue can't be controlled or made worse, but police and SARS must act, and it's not related to the bill. So I don't want to allude to illicit trading. But I also want to touch on the question about nicotine and cancer. So evidence, and I can definitely, unfortunately, can't share it here, but evidence shows that tobacco smoke and nicotine can increase the aggressiveness of cancer by promoting cell proliferation, migration, invasion, metastases as well. So it definitely has a role to play in terms of patients who are receiving cancer treatment. It definitely will affect their outcomes if they continue to use nicotine replacement. So I just wanted to touch on that. And then in terms of one of the questions that was asked about policies, so I just want to say that given cancer's track record on successfully advocating for stronger tobacco legislation, the sugar tax, and other public health measures, we are well positioned to support the implementation of the bill and help protect South Africans from preventable diseases. As cancer, one of our strongest priorities is reducing tobacco use, which is the single most preventable cause of cancer. We therefore expect and strongly encourage government to put in place policies that will significantly curb tobacco consumption, regulate vaping, and protect people from secondhand smoke. These include full implementation of the 100% smoke-free places with no exemptions, and everything else that the bill alludes to. So in terms of one of the questions that was asked about 100% smoke-free public places, we believe that stronger legislation will allow South Africans to understand the seriousness of using tobacco products and the effects of it. And we expect South Africans to understand that and to be able to aptly decide on what the future is and where they should be smoking. We're definitely not implying that people will end up fighting with each other and things like that. But we believe that South Africans will embrace the legislation once it is passed. So we are not advocating for banning of vapes, but rather regulating, including content of these vapes so that we can prevent cancer patients from unregulated products. So these are the provisions of the bill that we hope will definitely help cancer patients to also quit using tobacco products. In terms of the illicit trade, sorry, Chair? Sorry? Can't hear. Sorry, I can't hear anything. I'm not sure if anyone else can hear.
We can hear you. Continue.
We cannot hear the chair.
The chair is trying to say something. Okay. Okay, I'm just going to say something else. I'm not sure, Chair, I'm sorry, but I can't hear you. So
We
evidence
can
shows that.
hear you very faintly. I can hear you.
Oh, me. Okay, I can hear you now. You were trying to say something. Were you
No,
commenting
I
on
was
my sound?
checking. Yeah, have you finished?
Yes. Oh, so what I was trying to say, Chair, is that I will send through a formal submission in terms of some of the questions that were raised that I didn't answer. I also want to stress that smoking prevalence dropped in the early 2000s, and it shows that the provisions can be enforced and be effective. The problem now is industry interference leading to illicit trading. Thank you.
Okay. Okay. I hope you can hear me, honorable members. Towards the end, I could hear Miss Governor very.
We can't hear you, Chair.
Chair, we lost you. Right. Ms. Machalamba, please check who chairperson. Chairperson. Not chairperson. You are lost, Chair.
We can hear other people on the background, Chair. Not you.
Is in another meeting. I think let's allow him
I
to
think
come back.
we can continue in the meantime.
No, the presenter is done. I think let's allow the chairperson to come back.
Could I just check, Mr. Majalamba, is this was that our last presentation, or was there another presentation that we are waiting for?
That was the last presentation according to what was on the agenda. That hence I'm saying let's wait for the chairperson to come back and wrap up.
Okay. Hello, Miss Shabangu.
Thank you,
Can
Chair,
you hear
for
me
coming
now?
back. Yes. You were in
I was
another meeting, Chair.
No, I was getting into a car because they were chasing me out where I was. I was in another place here now. Can I be heard? Is it audible now?
Thank you, Chair. Yes.
Yeah, Miss Governor finished and said that she will send us some of the comments, which we will welcome. I was thanking all the members who have logged in since 2:30 in this meeting, and also thanking our staff for their availability and support, and said we will meet again on Tuesday at about close to 3 o'clock to start another process like this. And I might have an update next week regarding our request to visit some other countries on this issue of the bill. But thank you very much for this, and thanks for your understanding that sometimes we move from one place to the other, getting chased. I was thinking, I was not aware where I'm seated that they want to close at 7, so I had to get out and be in another place next to the car. Hence, I was going past some noises. Thank you very much, and good evening to all members. Thanks.
Long live the Chair.
Thank you, Chair.
Thank you very much. Bye-bye. Bye.